Hi, everybody. This is Practical Wellness with Courtney Davis and Jasha Connor. We're coming at you with episode 2.
Hey, Courtney. Are you ready for episode 2?
I'm ready.
Are ya?
Yeah.
What are we going to talk about today, Courtney?
Well, today, I think what I want to talk about is one of the biggest problems that both clinicians and patients face in healthcare. What do you think it is?
Let's see. Access?
Access. How'd you know?
Easy. That one's easy.
I actually had a patient today who came in for her follow-up on her weight management program. And she's like, can you please see me for a sick visit because I can't get into my doctor? And I was like, yep, absolutely.
I had one yesterday, and just the exact same thing. You know, they want to go to their primary care. They can't get in. Urgent care is like hour waits, ER hour waits. So,
oh, yeah.
Yeah.
And also the misuse of the ER. Like, we don't need to go to the ER unless we need to go to the ER. So
No. And most of the times when we have to utilize ER, it's because we can't get into our primary cares. And that's why we overuse ERs, you know, because you can't get an appointment.
Can't get your appointment, or the next available appointment is 2-3 weeks later, or even 5 days later is still too long when you're sick. So there's no, and that's one of the things that I'm super excited to talk about today is the fact that there is no sick care in primary care anymore because the system is so bogged down, and that's why access is so difficult to achieve.
Yeah, you can't get a same day appointment in primary care. It's just, it's
very
not feasible.
Rarely. Right. Very rarely. And Jasha, that article that we spoke about on episode 1, I'd like to bring that up again today because we just touched on it briefly. But the primary care providers, based on a study by Johns Hopkins, said that it took 26.7 hours. That's how many hours it would take for one single clinic day to take care of all the things that are, need to be done, whether it's preventative care, counseling, chronic disease management, and then managing the inbox and the return calls and all of those things that encompass primary care. 27 hours.
Yeah. So what ends up happening, Courtney, is that, these providers, they don't have time to do it through their actual day. So they spend their weekends doing it. And then it leads to burnout. Physician burnout, nurse burnout is an actual real thing. Very real thing. That's problematic.
Yeah, and it happens really fast.
Oh, yeah.
You think about if you're, balls to the wall 100% of the time, 5 days a week, how long is that sustainable before you say, what am I doing? And do I really enjoy this job anymore? And am I caring for people the way I want to be or how I should be?
And it's not sustainable, but a lot of the times it's not even recognizable until it's too late, until the burnout is so bad that, you need a month off of work to actually fix the burnout. But the problem is, when they're so burnt out, Courtney, the risk for the patient goes up. How far? I know you have that article in front of you that talks about that.
I don't. I do have it in front of me, but I don't recall reading where it said.
It's like you're 2 times more likely when your physician is burnt out that you're going to get a mistake, that there's going to be an error, because it increases patients' errors when you have physician burnout and nurse burnout. I've seen several times, if your patient's in the intensive care unit, you're going to hope that it's not that nurse that's doing her 10th shift, 12-hour shift in a row that's caring for your family member.
It's true,
and that's a large reason why I am so for family involvement when patients are in the hospital. And there's a lot 100%. Of back from that. And there's different reasons for us doing that, but in the same sense, for instance, when my dad was in the hospital, I'm not going to name hospitals because it happens everywhere. This is not, this is not distinct to one place, but
oh no, we're in 2 different regions of the country.
Yeah, we are, but we experience the same things even in the different regions.
Right, absolutely.
And my dad was suffering from delirium, drug-induced delirium, and I had to beg the staff to let me stay with him overnight, so that I could prevent medications, so that I could prevent harm to other people. Or so they didn't just have
to continue to dose him so that they could get through their shift.
Yes, and drug him more so that he just, it's not better for the patient, but a lot of the times we have to do those things in that situation to maintain safety for our staff. Yeah. But if you allow family to come in, I went in there, sat beside my father, he got off all medications and had no issues. After that. But we forget that how important family involvement is.
No, and family helps a lot to reduce errors, and it helps with the continuity of care even, because when there is shift change, if that family member as a constant in the room, they can kind of help. They're an advocate, and we should welcome family, whether that's in the clinic or in the hospital setting. We should welcome it. And like you said, the burnout happens really fast, and it leads to poor outcomes and decreased patient satisfaction, right? So a lot of the times you're like, oh, how many times have you heard somebody say, my doctor did this and it was wrong, or my provider ordered this, or they misdiagnosed me here or there. And a lot of times that isn't because they weren't knowledgeable or they didn't have the resource, but they didn't have the time, which is sad, super sad, because that should never be an excuse. We should never just, it's not an excuse, but it's the reality. And so it would suck really bad to say, well, I didn't mean for this to happen, but I just didn't have the time. And in our healthcare settings today, our clinic guidelines that are issued through, major what am I looking for here? What's the name I'm looking for? Who issues the guidelines? So, these clinical guidelines that are put out for us to follow are increasing at ever, super fast. We get new guidelines all the time, but patient allocation and spots on the schedule don't. So every single week, month, day, year, there's more to do in the same amount of time that we have allotted. And so I can't tell you how many times in primary care working for a large organization, we had one of the liaisons come to make their rounds through the clinics, and every couple of weeks they'd come by with another piece of paper or another workflow that we needed to add it to our daily regimen with each patient.
So you're already busy daily regimen.
Yeah, whether it was a survey that we had to do or another documentation requirement, whatever it was. And there's this huge push and pressure to get it done because of the reimbursement that comes attached to it, because it's not quality time or quality outcomes that healthcare providers are getting paid on. It's diagnoses and documentation. Yeah. And then in the hospital setting, of course, there is the reimbursement on patient satisfaction, which is a whole nother can of worms, which has contributed to a lot of the burnout in providers as well, I think, because we were pressured into keeping people happy and giving them what they want versus what they really need or what they should, accept as their plan of care.
Yeah. Well, let's be real, Courtney, like that patient satisfaction, like when we talk about that, we're talking about hospital reimbursements are a lot of the times it's based on patient satisfaction. So say that
always,
you go into the hospital. A huge
percent of it, not 100%, but a huge chunk of it.
You want a pain medicine. You want an antibiotic. You know what you want and you want it. And you don't get it. You go give a bad score. Insurance reimbursements are affected because of that. So there was a time to where doctors just started giving everything people wanted. It didn't matter if their clinical judgment was against it. We got to make them happy. And that came from above because they needed that insurance reimbursement to come back. And that absolutely contributed to the opioid epidemic that we're seeing right now because it happened in the ER. And now look what happens. This is what happens. Like we do something like that and we're like on board. Then we realize, oh no, this caused a massive problem. And now we're in an opioid epidemic. What do we do? So now ERs can't get
every
pain
cause
medicine.
will have an effect, whether it's negative or positive, and we need to be thinking proactively to prevent these negative outcomes, whether in our patients, in our healthcare system, in our personal clinics. It's a big deal.
It's a huge deal. And now we have people that have maybe been on pain medicine for several years, have legitimate chronic pain that can't get it. Now our answer is you're cut off. Like, where do we find that fine line and where do we learn from our mistakes in the past to understand that we got to do things a little better and a little more right? You know what I mean?
No, for sure. And that all goes back to the pressure of, the time constraints and how that affects the delivery of care.
Absolutely.
So when you don't, if you think about counseling somebody on nutrition, that doesn't happen in 45 seconds. You can't say, hey, you need to do this and follow this diet and do that and try this and just like throw it at them. We know that people will not be successful if it's too hard or it's poorly understood. So you have to give it to them in bits and pieces so that they can achieve, whatever the goal is that you've set with your patient. So you don't have time to do that. So it's just not happening because everything else has to happen.
Lifestyle coaching is not done 15 minutes once a year. That's not possible.
No, it's not. And it's the first step on any chronic disease prevention, right? Or management. It's lifestyle modification. And we just say it. We say like, oh, lifestyle modifications reinforced. Boop, done. Were they? In 15 minutes? It's just not happening. There was a time
also, though, that, society was really, they didn't want to hear it. And even though we had those that did, that's another reason we got burnout. We got burnout by getting shut down. Anytime we talk about weight or anytime we talk about lifestyle modifications, they say, don't you talk about my weight, and it's not like in my wellness center, it's not about getting skinny. It's not about your outward perception. I am here to give you lifestyle modifications because I don't want you to get into this system that's so messed up and that you're spending all of your retirement in specialty clinics and doctor's offices and procedure after procedure after procedure when it was just something we could have fixed, years back if we'd have taken the time to listen and do it.
Right. And it's truly about the health and wellness and true health and wellness, not just, I'm healthy because I take all these medications and everything's controlled. While that is a goal in its own, and if you do have chronic disease, we want them to be controlled, but there is some lifestyle modification in there so that you can start reversing some of these chronic diseases and get, well, and, not be dependent on these medications.
I think I just said this morning in a consult when I was talking about cholesterol. So, if you come to me and you say, yes, I have high cholesterol, I am not going to change absolutely anything. I don't want to do anything. I'm going to say you need to be on that statin because your risk of heart attack and stroke are far greater than the risk of that med. But the medication is toxic. So I'm going to try to talk you in to say, hey, what can we do to get you off this medicine? And that's what we need to be doing. Our goal should be to, yes, if you have high blood pressure, we have got to control it. But how are we going to get you off of it? What are we going to do to get you off of that medicine so you don't need it?
I do think that people and providers in primary care and even specialty care want to do these things. It just goes back to the biggest disparity in healthcare right now is there's so much time constraint. You can't do it all. So it leads to it just not being done and people being punted out to specialties to fix a problem or, like their cholesterol is not controlled. They're maxed out on their statin. Now what? Oh, send them to cardiovascular or send them to lipidology, something like that. And it's just, if we had the time and the availability to see people more frequently or, spend 30 minutes with them twice a month even to really talk about some small lifestyle changes and give them that accountability, I really do think that more people would be well because it's not that people can't do it or don't know how to do it. They need the support, especially because change is difficult, especially as an adult. I mean, it's not like we're getting 7-year-olds that we're trying to rehabilitate, right? Where you can just get into their, change their diets and their lifestyle behaviors and put them in a sport and now they're in love with it. These are 30 to 40, 50-year-old people who are regimented in their ways and they're busy with their lives and they've got kids and stress and jobs and do I need to refinance my house and should I shop around for insurance and what's for dinner tonight, and all of that compels on you and it's like, oh my God, I can't do one more thing. I'm not going to change my diet. I'm not going to change my lifestyle. I can't walk. That's just another thing for me to do. I'm too busy. But if we could get them in the clinic and just give them bite-sized information and little small changes that you can ingrain in them, it can become sustainable. And everybody knows that it has to be,
Courtney.
Yes, small. Yeah. And instead of here's this huge packet of everything you should eat and how you should move your body and we'll see you next year. And surprise, they didn't do any of it because nobody goes home and reads all the paper that we're sending home with people.
But and we say too that people really know how to be healthy, but they really don't, Courtney. There's so much misinformation out on the web and on Google and everywhere that talks about what their idea of nutrition is because all the focus is on weight loss. Right? But we got to stop focusing so much on weight loss, but focus on getting healthy because there's diets out there that will definitely make you lose weight, but it's not healthy. It's not the healthy way to do it.
You're so right because every day when I do any of my consults with anybody who's trying to get well and lose, obviously losing weight happens a lot when you're getting well because we're making small changes. And so a lot of one of the biggest questions that I get is they're like, well, what do I need to eat? And I just throw my hands up in the air. There's no restrictions. It is that easy. We're going to start eating less and we're going to start moving more and then we're going to take it day by day. And I don't want you to worry about that because if you make it too hard, it's not going to stick and it's not going to be easy and you're not going to do it. Yeah, and you're not going to do it and you'll be living this lifestyle and this tug of war with yourself for the rest of your life. So you let me worry about that and every time that we meet, I'm going to give you another piece, for you to build into your life.
Part of that, Courtney, though, is also I do like to give them education because I fully believe that knowledge is power. And if you understand and you have the education behind nutrition, you're going to choose the right option most of the time. You know, I think I told you I was blown away the other day with talking about processed meats. Does anybody even know that processed meats are a group 1 human carcinogen?
No. I mean, yes, people know that. Absolutely.
I don't think so. I think if we take a poll, I think we need a poll. I think people are going to have to comment on this and let me know if they know, because tobacco is a grade 1 human carcinogen. So processed meats are in the same category as tobacco. But we don't have warning labels in Walmart on bologna and hot dogs
we're all lined
that tell
up at the
you
deli
this is going to cause cancer.
Right.
You know, and a lot of that.
And I do think that some people know.
Some people
I don't think it's a
know.
huge secret,
Big
but you're right.
Knows. I'll tell you who knows. Big Food knows. They probably don't eat their own hot dogs and their own bologna. But it's not even something that as a nurse practitioner, you know, we are pounded. Stop tobacco. That's like one of our screenings. Do they smoke? Stop it. That causes cancer. Right. We know that causes cancer. But we're not told. Well, I never heard that in any class that I've ever taken throughout my healthcare education about processed foods and processed meats cause cancer.
No, I 100% agree with that, because that was not part of my nutrition class. It was not part of my oncology component, like none of that. So, yeah. So,
and
no, it is true. The way that it's available to us.
It is, but big food companies, it's the way they mass produce it too, and it's what they. That's why I promote buying your meat local. If you're going to eat meat, you need to get it local. You know, I do that all the time because I believe that it's cleaner and it's healthier. And if you're going to eat it,
tastes
get it
better
cleaner and get it healthier. It does taste well. It tastes better because it's not packed with hormones and antibiotics, Courtney. And
it tastes
that's
delicious.
got to tell us something. You know, it's
but there's
a lot of things
I
that
agree.
people don't know. You know, and that's our reason for doing this. We want them to know. You know,
right? No, I 100% agree. But the only way they get to know that is through conversation, right?
Yes,
and that conversation, those conversations are not. We're having them, right? We're having them with our patients, but it's not happening everywhere, and it's definitely not happening in traditional medicine and traditional healthcare.
One other topic I really want to hone in on when we do this podcast, Court, today is incentives. I want to talk about incentives because I think that this is something that the public needs to know, because this is another reason that our healthcare system is bogged down. There's several. That's why we're going to have many more episodes, because we're going to touch base on a lot of things. But I want to talk about RVUs. Do you have RVUs down there in Florida, Courtney?
You know we do.
I cannot stand the RVU bonus-based program. So I want to explain this to people a little bit. And so what this means is that as a provider, you get a bonus based on RVUs. RVUs are done by how many people you see in a day, how many procedures you order. So basically, that's an incentive.
And for those listening, RVU stands for relative value unit. So everything that you do, like Jasha just said, will have an RVU attached to it.
So the incentive
like
is profit.
Right.
You know, the incentive is not giving better patient care, but the incentive is how do we bring in more profit? Okay, we tell these providers they'll get a bonus based on RVUs, then they cram their schedule full of patients, more than they can handle. That's why they double stack, triple stack. That's why you'll spend hours upon hours in the doctor's office, because they're cramming people in, running them through like cattle because of incentives. And I absolutely am disgusted by RVU programs anymore. You know, it just drives me insane.
Poor.
Because that's why we do so many unnecessary procedures. You know, we bring people in too often. You know, our elderly are spending their times in doctor's offices when it's not necessary. You know, we talked about this before. A lot of the doctor's appointments that they even have, because they have 5 different specialists and primary care sends them here. Well, then they got to follow up with that specialist every 6 months. Then they have this specialist they got to follow up with every 6 months. Right. And they spend their entire retirement in a doctor's office when it's not warranted, but it brings them RVUs. That incentive-based program, I don't enjoy. I
and for an example, and Jasha, you and I spoke about this off camera. So, but for our listeners, for an example, you have a patient that comes in, and you're in your primary care setting. You're seeing your regular provider, and they're getting an RVU off of you, essentially, and everybody else that's on the schedule that day as well. It's not just you; it's everybody. And when they refer you anywhere else, those providers that you see there will be receiving those. And then even if you did or didn't need to see that specialty, they will keep you on their panel even if they're not making any changes. So we see a lot of patients in primary care that come to me and they're like, Courtney, I see these doctors all the time, and every time I go, all they do is read my lab result that you did already, or, they just say, oh, everything's fine. We'll see you in another 6 months or another year, or, whatnot. And they're driving there, they're waiting in the lobby, they get back and nothing, there's no intervention, there's no conversation, there's nothing. And so they really don't need to be there. They don't need to pay that $60 specialty copay or $50, however much it may be. They don't need to spend their time out of their schedule to do that. But it's kept there because, hey, now my panel's full and every little patient counts, because I get some dollars off of that.
To bring them back.
I know, that's what I'm saying. That's why it happens. That's why they do it, because there's value to it for them, but there's no value to the patient. They just think that they need to see these 6 different specialties when really whatever you made it there for already has been taken care of and it's controlled and it's maintained, and that you need to go back to your primary and just keep regular follow-up. And it's so sad to me, like you touched on, that people in their golden years, they're, approaching retirement or already in retirement, they're spending so much of their time in clinics. I had a patient the other day, her and her husband were here, and they take care of their mom. And they pulled up their phone and they showed me, look at this calendar. And it's every 2 or 3 days, there's 2 appointments. And I'm like, who in the hell is she seeing, and what? And then not only is that a burden on the patient, it's such a burden on the family and the caregivers, because they have to take time away from work and do this. And then when you put that in a rural community, it's even worse, because now they're driving 30 miles to get to these specialties because they're not available in their towns. And so it's really sad. And the money involved with the incentive is just a poor model, because you get bad health care from it. And it only perpetuates the lack of access that we already have. So the reason you can't get in with your primary care provider when you're sick, when you wake up with UTI symptoms or cough or cold or whatever it is because they've triple stacked their schedule so that they can to ensure that they have their bonus, and that's not all encompassing. I know that they're not all providers that do that, but it is a very normal behavior. You're right. It's promoted through administration. And
not all
it's
providers
promoted.
do that. I've known a physician that refused to take RVU bonuses because he disliked the model, just as we do. I think bonuses should be based on the quality of care that I give you. If I am taking good care of my patients, that's when I should get a bonus. Not because, oh yes, you've ran yours through like cattle today and you've saw 60. So here you go. Here's your bonus.
They should be directly linked to your positive outcomes and your better improvement and lower healthcare costs, right? Like my patient's so healthy and doing so well that they don't have to go to the emergency room hardly ever or ever at all. And then that is warranting of a bonus, right? That's great. And I'm not saying that people shouldn't be rewarded by any means for their duty and for their commitment.
But they should be rewarded for the quality of work.
Yeah, it should be linked differently, for sure. That you do. Not volume. Yeah. Value over volume. And so a little personal experience, I was, when I was working for a large healthcare corporation, I was RVU based. I had a base salary plus RVU based on whatever I could do, right? And there's thresholds involved and, it gets pretty detailed. But I would see 27 patients a day, 25 to 27, and that's pretty full. But I did not double book, and my patients didn't wait. I very well could have, but I didn't, because it's just, it doesn't even make for, that's why people are burnt out. It is a terrible day. If somebody would accidentally double book me, I'm mad, because I know that I already was so time constrained with the 15-minute slots that the healthcare organization allowed me anyway. And I will tell you that when negotiating my schedule and my contract, of course, they don't want to give you more money unless you see more people. You got to generate that money to get more money. And so there was, administrators and directors that, hey, Courtney, well, what do you think about turning your annual wellnesses into 20 minutes? Or, can you get these down to 10 for your follow-ups? And it's just like, oh my gosh, no, we're already only spending 7 minutes on average. If we reduce it even more, not only will my day be worse with documentation and hustle and bustle, but the patients suffer because they already are getting so little time with me. And so it's really discouraging to think that, but it travels up, it travels upwards. So the more money I make in the clinic, or the more people I see, the more money we generate, it goes up, like what they're paying us down here is way less than what they've already taken their cut. And so, and they may not and what's frustrating is they don't understand it from the clinical side of things either, because I say this with a term of endearment, but I call them carpet people or carpet walkers, because they're not on the tile. There's no blood on the floor. There's no sweat and tears. They're behind a desk, and they're looking at metrics, and they're looking at volume, and they're looking at bank lines, and they're looking at the business side of things, which is important. But I really, really wish that it was more synergistic when it comes to clinical care and like hospital management.
Oh yeah.
But that's a dream.
My favorite thing is when they actually take somebody who has been in the trenches and put them in admin. But it doesn't happen very often, Courtney.
It doesn't.
And a lot of that is, you call them carpet walkers, and I get that tone, yes. And they have an important role, but the problem is we grow too big, and then administration goes way too high, and they're not in the midst of the trenches. They don't know what's going on. I think one of my favorite things in the healthcare system was when they actually came down. Come see what's happening. Don't tell me to take 10 more patients. Come into this ICU and see what's going on, and then tell me your opinion. But don't just call me, from your office.
Or and I do think there are some very proactive CEOs and people in upper level of management that do come down and they help. I work in the emergency room still, and our director, like, he's in that ER every single day. He's down on the ground, and he's there to support. And then you have some that are not as proactive or whatnot. And so this, just like in anything, you've got good ones and you've got bad ones, but when we have this huge detrimental healthcare system right now, it's going to take all of us to put, the pressure and the accountability on the people that can make that change.
Yeah, and to do something about it. But I think us educating people is going to help put that pressure too, because they need to know what's going on.
We have the power. The patients they outnumber the hospitals.
They do.
And as soon as people are aware of what's happening and they're aware of what healthcare could be for them and how it should be, then I think that we will start to see a huge change. I do think that we've already started to see a small change, at least, in the DPC movement, the direct primary care movement. That came about 10 years ago, and just now are people really flocking to it because of the access to care. And like, you've got your provider in your back pocket on your app, and if you need something, it's there. And I can shoot a message to you if you have a question about, send me a picture of your nutrition label. And a lot of other providers may scoff at this, like, I don't want to be available all the time. Like, I have my own life. And that's a common misconception, is like, I still have my own life. I don't respond immediately all the time. I have office hours, but I sleep at night. My patients are respectful of that. They understand that, so there's a huge misconception in that, but
I think next time we need to talk about direct primary care, because I think it's something that we need to bring out to the rural communities. I think what we're proving today is there's so many problems. That's the reason we're going to have several more episodes. And I do think, Court, maybe next time we need to touch a little more on direct primary care, because I know I'm doing a different model down here, not the same kind of model that you're doing. I'm trying something a little different, and I'm excited that maybe next time let's talk about that. Let's let the people know kind of what we're doing in that era. Absolutely, that would be really fun.
How many times do you think I've said absolutely?
I don't know. I've counted today, and I think I've only done it once. But when I go back and listen, we'll find out.
That'll be our tagline.
We have goals, guys. We have goals. Less absolutely, less perfects. But hey, Court, it was great. It was great talking to you today. I love that we're doing this. I'm excited to bring the knowledge that we have to the people, and I'm excited to do more podcasts in the future. We will have a next one, and I think let's talk about some direct primary care.
All right, coming at you. Thanks so much today.
Yeah, nice talking to you, Court.
You too.